Yeah, as many people should join. Yeah.
Yes, sir. Yes, sir. Already 46 people have joined. I think
Not
let's
bad.
get
Very
one.
nice. Very nice.
So,
Let's see whether we can make a half century.
so mostly these are DNBs
But
and
this shows how popular you both are. Aapka network is very popular and very nice. Congratulations.
it is all because of you, the speaker like you, sir, and the topic you are presenting basically. So the very means one of the topic actually every PG student and every DNB student should ideally learn, and but there are very few papers and resources where they can learn actually. So that is the reason.
Prakash, I'm in a lecture. Can you call me back after some time? Yeah, message.
So, sir, I think we can start, sir. We have already crossed 50. So, welcome you all. So, today's 23rd session on Apollo Mumbai Clinic Critical Care Learning Network, and with us, very eminent speaker, Dr. Abdul Ansari, sir. So, sir needs no introduction, and today's topic will be going to be very interesting. The critical appraisal of a journal. Basically, this is very good for all the DNBs and all the PG students, So I request you to ask questions in the chat box and at the end of the talk. Sir is basically director heading the unit of critical care at Max Nanavati Super Specialty Hospital. And under his leadership, I think the hospital has taken a new turn in the critical care medicine. So let's hear from sir. So regarding this interesting topic, critical appraisal of a journal. I am Dr. Gunadhar Padi, the senior consultant, Apollo Hospital, Navi Mumbai, critical care medicine, and with me my colleague Dr. Akhilesh, consultant critical care medicine, Apollo Hospital, Navi Mumbai. So we both welcome you and all the delegates and speakers. Sir, please start.
So thank you very much. I must thank, first of all, Apollo Learning Network and this beautiful effort by both of these very young, dynamic critical care consultants, both my dear friends, Gunadhar as well as Akhilesh. And I think this is very creditable, and I must thank you all for inviting me here. At the outset, I would say all the students and all the interested colleagues and friends who are listening, a critical appraisal of a journal is an actually ever evolving process. I remember very well that it was the biggest pain when I was preparing for my exam in my days, and I'm sure it is the same even today. And there is a lot of literature. Evidence-based medicine is actually the backbone on which our current practice depends. And we being the newest of the what is called specialty on the block, we rely heavily upon evidence-based medicine. But believe me, evidence-based medicine and what is called experience-based medicine or eminence-based medicine, they can be differentiated by actually asking these very important questions of what is the trustworthiness of the literature that we study, what is its value, and whether it is relevant in our current situation. So with this background, understanding of critical appraisal of any paper or any scientific article is paramount for understanding and interpreting and using it in our current practice. So with this, this article, first of all, this presentation is by my colleague, Dr. Prachi. She has made an excellent slide and thought process which has been applied, but it has been heavily derived from the University of Children's Hospital NHS Trust, a very nice systematic appraisal, critical appraisal of a journal article. So it's drawing a lot from there and a lot of other sources. So I would thank Prachi as well as the contributing authors for providing this. And I would very strongly advocate that the Apollo group should disseminate this for all our deserving candidates. So when we talk about critical appraisal, it is a process of carefully and systematically examining research to judge its trustworthiness, value, and relevance in a particular context. And this is done by asking a few important questions. We call it PDSA, plan, design, study, and act in general parlance for any clinical understanding. But here it is like find the problem, P for problem. D is define your question. What do you want to know? If you have a problem about, let's say, infection, then you define what infection are you looking at. Then you search and find the evidence. If it is already appraised and present, your end stops. If there is nothing, then you create or find out a literature. And once you find the literature which has not been pre-appraised, you find the appraisal. So that is called as the PDSA for a critical appraisal. And once you have appraised, then you decide for yourself what is its trustworthiness, what is the value of this data and relevance, and use it in your own population to have your own evaluation. So this is called the scientific approach. And when we define the question, it is important to understand the PICO tool, which is about the population that is of interest, the intervention that we are talking about, the comparison, as well as the outcome that you get. So this is very important for all of us to understand. I hope my voice quality is okay and people are able to see this clearly.
Oh, yes.
Thank you. Thank you. So it is very important that critical appraisal should be done because there is actually information overload. And I'm not able to recall the number, but in the last 2.5 years in the COVID times, there was so much of evidence which was generated, which was very difficult to understand. And within a span of 2.5 years, half of those evidences were found to be useless, not relevant to the practice, and have been relegated to the past, or what is called as the bad science. And I call it the bad science, beyond headlines, or the biased publications. So this is very important that whenever you are reading an article, you need to have these tools of critical appraisal in your mind so that you combat information overload or useless information or futile research, identify those patients out of the papers who are clinically relevant, and also in the process, you have a continuing professional development. Now, CPD is a part that is called evidence-based medicine evaluation, which may be important for your exams. So sometimes you need to study only for the purpose of exam, but if you can utilize it on a day-to-day basis as an essential thought process, essential scientific thought process, or what is called scientific acumen, that could be the best investment in your own self. So moving on, when we talk about, just to kind of give you a few ideas, when we talk about what is the location of the study that you are getting from, is it from a newspaper? Is it from a quasi-science article or a pure scientific literature? Or is it coming from another subspecialty from where you are drawing it, like a journal of gastroenterology, and you're trying to look for something which is for importance for you? You need to look at what kind of study designs are there, what is the background from where it is coming, and whether there are certain inherent biases in those studies, biases of publication, or what is called as a Tower of Babel approach, the database bias, as well as the citation bias. Now, these are important things. Sometimes you get too influenced just because the article got published in a very good scientific journal. Sometimes you get biased because it has been published in a couple of areas, or it has been cited many times. And sometimes from very smaller countries where a poor scientific evidence is there, but just because it is a database from that particular country and enters into the larger global database, that small case series or study can get unusual leverage to show that it is a big scientific study. So this is very important, that when you look at the study design, you go for the understanding whether we are dealing with a qualitative or a quantitative study. When we talk about qualitative studies, they are to explore and understand people's beliefs, experiences, attitudes, behavior, interaction. And I don't know whether all of you would see it often. There are enough people posting Google Forms, asking about people's opinions, having monkey surveys, and all those things which can give you a lot of qualitative data. That's very essential in understanding and shaping your thought process, especially for documentation, for observation, passive as well as participant observations, and certain in-depth reviews of face-to-face conversations where there are no basic questions. You start some questions and have a focus group thought process, kind of crystallization. So qualitative studies are important, but they are not as grainy and granular as you would want to really understand and to change into some kind of a perceivable difference. But they give you an idea about where do you start from, where is your scientific community today, and what could be the systematic behavioral evolution. When we talk to the quantitative studies, these are the ones which are the movers and shakers of science today. Unfortunately, evidence-based medicine, what we talk about, is only based upon these quantitative studies because we believe the numbers have a power of conviction. Unfortunately, it is said that first you get your numbers, then twist it as you want to get your data. And that is something which is called as the data bias. When you get some database or some kind of a number, it looks very attractive. And sometimes it is very easy to get lost into that data mining or the data forest. So, but just to kind of give you an idea of the quantitative studies, case report, case series, case control studies, and cohort studies. Now, these are, even if there is a single patient report, that's also a form of quantitative study, where you are going to study about the changes in the pulse rate, the PF ratio with some intervention, or any kind of a number. While in case series, you are talking about a series of patients where there are no control groups. In case control and cohort, as the name tells, we are going to look at the areas or groups of people with similar kind of exposure or similar exposure of interest, and very useful in understanding the cause and effect and probably prognostic research. The key quantitative studies that we focus about are these three. Now, this is very important to understand that Haynes et al. In 2006 gave a pyramid of the strength of quantitative studies, where if you look at these studies, they start with expert opinion at the baseline of the lowest quality evidence. But again, that is called eminence or experience-based medicine. Then comes the cohort series, where you talk about a few case series as we spoke about. And then comes the RCT. So randomized control trial is somewhere high up in the hierarchy on the strength of a quantitative evidence. and then moving on to systematic review, meta-analysis, and finally synopsis and evidence-based guidelines. So that's called as the tower of strength of quantitative studies. The basic ingredient of that, which is qualifying as a good quantitative research, is a randomized controlled trial. So much so that RCTs have become the sine qua non for evidence-based medicine today. These are about clinical trials in which participants are randomly allocated to a test treatment and a control arm, looking at concurrent enrollment and what exactly happens in the therapy or intervention arm or a prevention arm. This has, by consensus, become a gold standard in testing the efficacy of any intervention. When we talk about systematic review, we are looking at critically appraising research on a specific topic with multiple valid studies of increasing importance from different reviewing areas or populations and clubbed together. And there you look at the strength, and which is far better than RCT because it is more than one randomized controlled trial. And finally comes the meta-analysis, or what is called as a network analysis, where there is an extensive usage of quantitative methods to summarize the results from a larger population base, eliminating more of these biases which come in smaller studies. And we will talk about those biases later on, that in every randomized controlled trial, there could be at least 4 important biases at various levels. And right in the beginning, called selection bias while you are taking the inclusion, the performance bias while you are doing the test, the what is called exclusion bias, where sometimes some people out of the study are dropped out without any intention to treat analysis. And finally, the detection bias based upon the efficacy by which you can pick up the results. So those would be the inherent biases in RCT, but nonetheless, an RCT still remains the standard of choice when you are talking about an appraisal. So when you look at an RCT, the few important checklists for critical appraisals are mentioned over here. Look at these 5 major headings. What is the study question in research that you are trying to answer? What is the randomization that you are going to do? Were the patients in the intervention group and control group randomized in a concealed manner or an open manner? What were the patients in the group similar to at the start of the study? So that's called the randomization, where you're doing a good randomization. When we move to the next point, it is blinding. Were the patients and the clinicians blinded, and were the analysis being done by blinded people? So single blind, double blind, triple blind. And I would say everybody blind if the question is bad. So that is called complete blinding of the study. So, or I would say the blind spots in the study. But blinding is important. And finally, follow-up, where all patients accounted for at the study. How many patients were lost to follow-up? Were the patients analyzed? And this is very important, where you can have a lot of exclusion biases. And lastly, the intervention and the co-interventions. Were they sufficiently detailed? And was the only intervention change very clearly captured? And were the 2 groups cared for in similar way, except for the study intervention? So that's very important, that were you really performing the study well? So performances biases, selection biases, the exclusion biases, and the detection bias. These all things should be looked at while you're looking at the methodological aspect of the study validity. Now you move to the results and finally the applicability. So if you look at the study validity, the results, and the applicability. When you talk about the result, the selection of outcomes, does the article report all relevant outcomes, or they're only talking about composite outcomes? Are they separating all the outcomes and then talking about composite outcomes also? What is the effect size? Was there a very clear-cut analysis done or power analysis done to really understand that the kind of expected baseline difference is picked up? Because the number should be adequate. And how reliable was the estimate? Was a statistical estimate done? What were the confidence intervals? And last but not the least is the applicability. If you are reading from a pediatric article and you are practicing in an adult practice, I think you are going to draw absolutely weird conclusions, which may or may not be necessarily true for your population. So using the results in your own setting, are your patients so different from those studied that the results may not apply to them? And is your working environment different? You're not using Swan gains and you're trying to study the hemodynamic effect of a particular drug, which is being measured by a cardiac output based on Swan gains catheter. So that could be a major limitation for applicability in your setup. So I hope by this time, most of us have clearly understood the 3 important aspects of critical appraisal checklist: study validity or methodology validity, Then you talk about the results, the validity, and finally the applicability in your clinical practice. Clarence Day said there is an art of reading as well as an art of thinking, and there is finally an art of writing. So this is what is called as a reading, thinking, writing, or reading, speaking, finally making you a ready man. And writing is an essential part of presenting it to the other audience. And this is where we must understand that when you talk about a scientific article, there is an art in which you read that article. So here I will try to, kind of collate something that all of us need to have in our mind, that when you are reading this article, first of all, skim the article very quickly, because sometimes they could be so dissuading that you may not be able to go through the whole article. So look quickly over the structure of the article, where it comes from, and look at the abstract, which is already given, and then go across and then come back. So most journals use conventional structure, which is IMRD, introduction, method, result, and discussion. Somewhere in between, there could be other kind of selection criteria, the forest plots and kind of meta-analysis, but in general, this is the conventional way. Introduction, method, results, and discussion. And each of these sections normally contain easily recognized conventional features, and the features of these abstracts would contain 4 kinds of information: why, how, what, and what does it mean. They are just not limited, but these are called the whys, what, and other, the 5 or the 6 W's that people talk about. But this is very important, that IMRD, introduction, why did you do that? Methodology, how did you do that? The results, what did you find? And finally, in the discussion, what did it really mean? Distinguish your main points once you have skimmed through the article. What was the document level? What was the author's main points? What are the title, abstract, keywords, visual figures and table titles, a first sentence or at least 1 to 2 sentences of the introduction. This is very important, where you are understanding, okay, you are getting started. What am I looking at? Look at those words or phrases, which will give you an idea to also what is called as the search engines will give you an idea. And you have to look for these particular types, like we introduce, this was an unexpected, we hypothesize, in contrast with previous work, we propose, surprising, has seldom been addressed. So these are certain phrases which will give you a lot of idea about what we are going ahead with. And then you ask the questions, what are being generated, and you are aware of your understanding. Before and during your reading, you must understand that who are your authors, what journal is this, what kind of credibility it may come back from, what is the understanding for all the terminology, do I need to do my brush up before I go for that, and is there someone I can talk to about these confusing parts. And after reading, you are again going to go back, how does it really help my area of work, why is it important, is there a persuasive evidence, what are the specific findings, how would I summarize, and how will I discuss this with another colleague of mine, and whether there would be further more studies required to really take it to the clinical arena. And finally, drawing inferences. Now, it is very easy. Sometimes drawing inferences are very easy, that sometimes data may not be material and very important, and sometimes those data can sound very interesting. So readers who actively draw inferences are better able to understand and recall information. So you need to have either some prior knowledge or some kind of background articles that you have gone through, and then you draw these inferences from the study in question. And take notes as you read. In fact, the best way, and I always say that the margins in books are always for writing down your notes. So you write your notes or make some kind of a small cues which can give you an idea about recalling the main points. Develop a template for recording notes on articles you read. And as you accumulate a large collection of articles, this will actually kind of help you in writing some kind of meta-analysis or working on some synopsis or writing some kind of an appraisal or editorial sometimes. So when we move on, how do you look at the randomized control trial? And looking at these essential parts, we talk about randomization of the sequence generation, where you talk about how was the allocation done? Was there any concealment of the generated sequence done? Was the trial arm, the participants in the trial arm and the intervention, what was the only remaining difference? And it is very critical to assess the randomization process. So you must look at what was the basis of randomization and how were the sequences generated for that. Finally, allocation and the concealment. It's very important that how much effort the authors took to realize that there was no bias coming at this point of time. No selection bias was done. Investigator and the patients had no idea what they were doing, and was there a centrally based randomization and allocation procedure. Blinding, the masking of treatment allocation to investigators and also the people who are doing statistical research. So a single blinding or a double blinding will mean whether the participants were aware what is happening, whether investigators were aware, and whether other people who are putting and doing, providing the therapy, whether they were also involved. When we look about the final inferences, you must know what kind of follow-up was done. Was it a very short follow-up or long-term studies were done? Was there a loss of follow-up in the whole process? And it is very important to understand that 5 to 10% loss of follow-up is acceptable. But more than 20% dropout means that the results can get highly skewed. We'll talk about that. Finally, intention to treat analysis, once you have decided that these are our study participants, if they are crossing over or are getting dropped out, you don't forget that you have to take into account, because you are doing an intention to treat that group. If you have 400 in both the arms, and finally there were 10 or 12 dropouts in both, you need to look at what happened to them as well. So preservation of the benefits of randomization and avoid the introduction of bias during analysis. Results, the larger the proportion of participants who experience the outcome, the greater the precision. So there we will talk about the p-value, which means 5 out of 100 or 1 out of 20 can be probably by chance, but anything more than that is not by chance. And that's what we will talk about. So this is why this p-value of 0.05 that we talk about is always important, that 5 out of 100 can still happen by some chance, but anything more than that is an effect which can be attributable to the kind of intervention being done rather than by chance. And looking at what are the differences in continuous factors, what are the time to event analysis, and what kind of length of time has taken for the particular event of interest to occur between the groups. For example, renal failure development after giving a drug. How much time did it take? If it is happening on the next day itself, or it is happening after 2 weeks, again, the association may become very, very less grainy. So this is very important that you look at how quickly those effects were generated, what composite endpoints were happening at what time frame, and the clinical implications. For this study to be important for you, whether these can be translated into benefits for your patient, and whether you will be confident enough to use that in your own study, or unless you will be waiting for more evidence to come. So this is a kind of simple snapshot just to kind of go through. We'll spend some time. How do you do an appraisal for RCT? Let's say there was a question, were participants randomly allocated? Now, what is a good example and a bad example for this random allocation? Good example is centrally based telephone system, web-based online system. There are balance between the groups, balance of characteristics between groups may indicate successful randomization. There was a computer generated sequence. So these are good examples of random of allocation, while the bad example could be alternating allocation. That's very casual. Allocation based on birthday, hospital number, day of admission. Characteristics are not balanced well in the two study groups, and there is an inadequate or lack of effective randomization. Now, next question was, were the allocation, concealment, and blinding where possible used? So in good example, sequentially numbered, opaque, sealed envelope, numbered or coded containers, investigators, participants, and data analysis were all blinded, triple blinding. While a bad example, sequence numbers are publicly posted. So you knew that it is 7 means it is going to this arm. Use of translucent envelopes, inadequate or complete lack of blinding. So they are bad examples. Follow-up. Now follow-up, when we talk about, a good example is all or most participants completed the study and they were accounted for. The numbers were accounted for. While in a bad example, a substantial proportion of the participants withdrew, or no description of participants who were lost to follow-up. Was data analysis according to intention to treat principle? That means, were the participants analyzed as part of their originally allocated group? If you were into, let's say, a CRT group, then were you kind of completely followed for? Even if you dropped out after 5 or 7 sessions, you can't go or randomize to another group or crossover trial. And participants who discontinued were still included in the analysis. Why did they discontinue? Maybe you're not getting enough results and you stop analysis there. So that's called intention to treat analysis, and it's a good example. While a bad one would be participants were not analyzed as part of their originally allocated group, participants discontinued from the study or were excluded. And finally, are the results reliable? That will be dependent upon the account of all the other methodological considerations mentioned above. Edward Gibbon, who wrote the classic book of Rise and Fall of Roman Empire, said that let's read with method and propose to ourselves an end to which our studies may point. The use of reading is to aid us in thinking, and this is very important. So why you read a paper is to really help you in thinking. Either you understand that this data is really not beneficial, or if it is beneficial, how does it aid in your thinking process? Now, with this, let's try to appraise a paper together, which can be like a practical exercise. Let's see how we can learn on a practical scenario. So this could be a rough template for taking notes of research articles, where you have a complete citation of the author, date of publication. You have the web access mentioned, keywords you write down, general subject and specific subject. Then you come to the hypothesis generation, methodology, results, summary of key points. So if you kind of keep this kind of a note, you can thrash out any article into this kind of one page, and you will never forget what exactly you tried. And I would highly encourage all of the students before exam or while they are doing a new critical appraisal to have a similar template on which they make their own notes. And then you will never be able to, kind of get confused about the outcomes, because you are thinking while you are reading, and you are putting the context, significance, and important figures and tables together. So this would be a very important template to keep, as in general, trying to understand the appraisal process's methodology. Now, this was one of the most landmark articles. We all know Pro Seva Study Group, June 2013, prone positioning in severe acute respiratory distress. Claude Guerin et al., a large group, the Pro Seva Study Group, did study about the impact of proning in ARDS. Now, we start with the trial design. What exactly is being done? 26 ICUs in France and 1 in Spain. So 2 different countries, multiple ICUs who were using prone positioning in daily practice, and was studied over a period of 5 years. Randomization in a proper computer generated and stratified according to the ICU. Written informed consent, and data collectors were aware of the study, group assignments, but outcome assessors were not blinded. So that's looking at the trial methodology, reasonably good, multi-centric. You are looking at good randomization, computer generated, good information, so basic ethics, and finally data collectors were aware, but the outcome assessors were aware of that. So there was not a complete triple blinding, but reasonable blinding happening. Inclusion criteria. What was the study population we were looking at? ARDS, now defined by grainy American European Consensus Conference criteria. Intubated mechanical ventilation for ARDS, less than 36 hours. A very clear article where the ARDS was fresh. Severe ARDS defined by the authors, PF ratio less than 150. Now, this is a poor part, because in your general literature, you will say the severe ARDS is less than 100, or the FiO2, which is more than 0.1, more than 101, or the PEEP, which is more than 8, and tidal volume, probably 4 to 6 ml per kg. So here, this is a little bit of deviation from the standard practice. So you can always say that they did make certain changes. And if you want to apply it to your own study, if you have very, very refractory ARDS, probably you may understand that the study bias may come in, because there were people who had a PF ratio of 100 to 150 included in that. Now, this is important, but still you can kind of extrapolate, knowing that if I have a PEEP more than 5, which is very low PEEP, but an FiO2 more than 70%, and the patient is coming into moderate to severe ARDS, you can extrapolate this data. So this is important to understand the inclusion criteria. Very important, what contraindication were taken out. So if you are looking at a neurological patient post head injury who has developed an ARDS, he is not the patient where you can extrapolate this data of proning. Intracranial pressure, massive hemoptysis, tracheal surgery, sternotomy, serious facial trauma, DVT, cardiac pacemaker, unstable spine, MAP less than 65. So hemodynamically unstable patients on all of these, and these are a significant exclusion criteria. And this is very important that you cannot take this data outcome to this kind of patient population. Other ones, end of life issue, another research protocol. So if you were having more interventions, for example, you were giving some kind of immunomodulatory therapies, that's not justified because there could be a treatment bias. Previous inclusion in the present study prone, before inclusion already done, subject deprived of freedom or opposition from next of kin. So again, a lot of people may not have consented. So the real population might have been excluded. So there could have been a mild amount of selection bias. So this is, then comes the complete analysis of the methodology. How many patients came into the broader ambit in 27 ICUs from that period of study of 5 years? Of that, majority did not have ARDS. Now, this is the right way. You don't start with 47,000 or 3,400 patients had ARDs. You look at in the 5-year interval, what kind of skimming of the population was done to show the width of the literature. So if you write 3,400 ARDS, that may probably come with a question because you're talking about nearly 1 in 5 patient over here. Sorry, it's really kind of 1 in 15 patient, probably a 1 in 16 patient is landing up with an ARDS. This is giving you a background attack rate of the disease. Then you look about the screening, how many were not screened. Now that's a bad number which were not screened out, but anyway, there could be a lot of logistic limitations. Then the ones which were screened, why these were not eligible, there should be a kind of job. So they have discussed about the non-eligible criteria, end of life decision, another research protocol, previous inclusion, which means that probably you are still talking about 50% of an eligible population being studied. Now, this still tells you the realistically, maybe the application would be only in your 50% population. And after that, once you are eligible, 1/5 or 1/6 of those patients were excluded because either they improved, they had organizational problems, or they were withdrawn by the physicians. And lastly, you come to a number of 474, which is exactly less than 1/10 population. So this is important. So if you have 10 ARDS patients, maybe you are actually talking about 2 or 3 patients coming into this kind of study by mutual exclusion. So you may not be able to, even if you may have good result, may not be applied to all of the patients because of other reasons. Finally, when you get randomization, what you did in the two group. And this is very important to understand that logically 3,500 patients, you got only 474 patients, of which 5 and 3 were moving out. So finally 466 remain in the intention to treat analysis. Now, whatever happens to these 229 and 237 supine prone, that has to be completely accounted for. And this is very important for a duration of 90-day follow-up. So this is important that you conduct your research in this way and look at that every number was accounted for. So this is a very honest appraisal about your methodology and the numbers, and looking at the kind of complete review of the inclusion and exclusion criteria and the primary and secondary outcomes that you want to look at. Now, after having done that, 12 to 24 hours stabilization period to verify inclusion criteria prior to randomizations, patient assigned to a supine remained in a semi-recumbent position. Now, here you look at the comparison of the ventilatory settings, tidal volume, matching, tidal volumes, ml per kg, matching, respiratory frequency, PEEP, FiO2, P-plat, compliances, static, PF ratios, PaCO2s, arterial pH, and plasma biochar. Now, this is one of the most important strengths of this study, where your post-randomization, both the groups in a similar number had a more or less a similar pattern to start with when you had randomized them. And then when you have randomized, you're looking at the equality of the data. And this is one of the most important strengths of this study. Then you look for intubation criteria confirmed after 12 to 24 hours, severity criteria plus PEEP criteria, FiO2 and VT taken in, inclusion randomization, supine and prone on 2 arms, and then you're looking at lung productive ventilation to continue, because that's the standard methodology for all of them. And this is where you are looking at P plateau and the tidal volume, which are looking at, and sedation, analgesia, neuromuscular blockade going on for all. Now that's called as a similarity. So the only thing which is different is the supine and the prone positioning, and rest everything is fine. And after that, you are looking at the PF ratios, PEEP, stop sedation, weaning in pressure support ventilation. Everything is very clearly written and categorically written down. And the only change comes in is about their randomization into one of the two arms, and you are continuing rest everything in the same manner. So barring that same intervention of prone positioning in the hour after randomization of 16 hours per day, there is no other change. And even they might have mentioned how many times they have done that, maybe 3 times, which could be 24 hours apart. The measurements performed every 6 hours, just before turning prone, after 1 hour of proning, just before turning back, and 4 hours, and AVG and P-pad RS were measured at 3 time points. Very crystal clear. And in every patient, then you have to look whether these data were completely complied for. Criteria for stopping prone: if the oxygenation improved beyond the defining point, that means it moved towards the mild, moderate to mild kind of area, or the PEEP came down, FiO2s came down. So these criteria, which were at the time of randomization were set, have been fulfilled, and the patient moves out, or the PF ratio deteriorated by more than 20% related to supine before 2 consecutive prone sessions. Complications, as we spoke about, these would lead to immediate interruption of that kind of inclusion. So non-scheduled extubation, mainstem bronchus, ET, hemoptysis, cardiac arrest, systolic blood pressure, any other. This is very important. So if you are looking at your own data understanding, if you have already thought that the patient was prone and something went bad, and after that the patient died, it's not because of prone positioning that the patient died. This is very, very important to understand, that when you draw the conclusion, you must understand that the prone patient should not land up into any of these things, or neither the supine patient should land up into all of these issues. Data collection: patient alive or dead, the times of ICU admission and data quality was verified by research fellows who rechecked every entry, and this was going on for 28 days and 90 days. Results: the randomized control trial means PF ratio, supine or prone positioning. Most patients had ARDS due to pneumonia, about 60%. Most received vasopressors, 70 to 80% neuromuscular blockade. So you know that this is a classical patient profile in your ICU, in an adult patient who is severe one. And those randomized to supine position may have been slightly sicker at baseline. Mortality benefit was still significant after adjustment for baseline SOFA scores. And on average, prone patient received 4 plus minus 4. This is very important. So maybe there were some people who got hardly a single prone session, and some went up to 8 proning sessions, lasting for 17 to 20 hours. Somewhere it was probably less. And these patients were prone for 73% of the time spent on a ventilator. Now, this is very, very important point that we have to understand, that in a day, they were being 73 to 75% times being prone. And this is what you have to draw. You cannot say that I am proning 12 hours and I am collating the same data and trying to influence my research. And finally, you look at the primary and secondary, which were very clearly defined: the primary outcomes of mortality and secondary outcomes of time to successful extubation, length of ICU stay, ventilator-free days, pneumothorax, and other complications. So when you do that, and look at all the supine group and prone group, and look at the interventions. So at day 28, what was the mortality? 26 versus 11.3. At day 90, whether this mortality was sustained. And finally, was there a successful extubation? So it was in 65 patients over here as compared to 80 there in prone positioning. Survivors, there was a slight, kind of change in the non-survivor population. Length of ICU stay, ventilator-free days, tracheostomy, how many of them required, more patients required tracheostomy in this as compared to that. So prone positioning significantly reduced 28-day all-cause mortality compared to supine. And now you will see a number that is 16 to 32%, and then you calculate a hazard ratio. That means how many times. So if the hazard ratio is more than 1, that means it is more hazardous. But if it is 0.39, that means you have a 40% less likelihood of going bad as compared to the standard that you are talking about. And when you talk about the NNT, that is called the number needed to treat, which means if you treat 6 patients with prone ventilation, you may be able to save 1 life. And when you look at the P less than 0.001, that means the treatment effect is very, very significant, and maybe less than 1 in 100 was having a chance improvement because of prone positioning. So it was a therapeutic improvement in majority of the patients. And when you talk about proning, also reduced 90-day mortality, which was the long-term mortality that we are talking about. There again, the hazard ratio was sustained. That means the benefit lasted from 28 days to 90 days. That is 1 month to 3 months. This whole effect lasted. That means it was a substantial effect which could be attributed to the intervention arm. And when you talk about the discussion, then you look at the other ARDS trials that they have quoted for, where a lot of things had failed. And then you understand how difficult it is to have a positive trial in this group. And what was the power for the 28-day mortality rate of 60%? Now, usually an 80% power should be ideal. So you can always say that this was not a great power, but a post hoc analysis showed that there was a 90% size. This is something that a statistician may be able to tell you whether it was really maintained, whether there was previous proning trials were favorable, that has to be found out, and whether early intervention that they spoke about of 36 hours of ARDS, was that the selection bias? And was it the most appropriate patient using a 24-hour stabilization period and the significant proportion of time spent? So these would be the discussion points that you need to ponder upon. That was it really an adequately powered study? Well, it looks like retrospectively as well. But was the intervention only because of proning, or was it because of early recruitment? Was it because of selecting the right patient and stabilizing them for 24 hours? And was it also because of significant time spent on proning? So these could be the important thought-provoking questions for you. And finally, when you talk about the conclusions, that proning can be done without purchasing a new bed or special equipment, that because they are doing in the same ICU, can reduce the mortality. And the biggest limitation of the trial is that the nursing staff had years of experience in proning because they were done in those French ICUs where they were doing that. It is unclear whether less trained staff may experience more complications. Finally, a reduction of 50% in mortality is absolutely unheard of in ARDS literature. So should you take it with a bag of salt? It is too good to be true, or it is difficult to ignore. So these kind of conclusions, when you come back with on a single study, then you look for more data, more similar randomized control trials, look at meta-analysis, and if everything is watching towards that, then you know that if there is a kind of discordance of outcome, then you need to look at those specific strength of the inclusion in this or the methodological advantages. But if other data are also showing similar results, then you can conclude that yes, this therapy is strong enough in its own right to give the kind of responses. Thank you very much, all of you, for a patient hearing. And I think we can now take some questions at this point of time.
Yes, thank you, sir. Very wonderful. And there are a few questions in the chat box. So one question is, what is modified intention to treat analysis, and how it is different from the conventional intention to treat?
So honestly speaking, modified intention to treat analysis is more about, looking at any kind of change in the outcomes that we talk about. But intention to treat analysis is always about the clinical question that you wanted to really address. Is my screen still broadcasting? No, sorry. Sorry, am I audible?
Yes, sir. Yes, sir.
Yeah. What was the?
Yes, you're audible. So how does it help you? I mean, if you're trying to look at the modified intention to treat analysis versus the usual.
No, so as far as I understand, I may not be the right person, but as far as I understand, the modified intention to treat analysis is something where, you have excluded the participants who did not participate the whole protocol. And that's where you have kind of modified. So that's why modified intention to treat analysis, if it is not mentioned in the beginning itself, is not the best way to look at the results. Because supposing that you have kind of some protocols were not adhered in the middle of the procedure, and you still kind of continue to look at the clinical outcomes, then it becomes a MITT. That's what I feel. And intention to treat analysis is very clear that if you have randomized and taken them into a particular arm, then you keep on following till what exactly happened in that arm, irrespective of any change or any kind of an outcome drop, or if they chose not to continue with the study.
So it means if you are able to adhere to your exclusion criteria as well, so that becomes modified intention.
Correct. Correct.
So how about the role of number needed to treat? We often see in any journal or in any article, like we look at it, what is the number needed to treat? Some journals show number needed to treat is 2 or 3.
So there are 3 or 4. Sorry. So there are 3 or 4 numbers that we must. Sorry, complete. Sorry, please complete.
Yeah, and then sometimes in some journals we get the values like, you have to treat 100 people to really get a substantial result, to translate to your out. So how does that help? You have
So
already nicely elaborated on that, but to clear this doubt, I would like to ask.
So, Dr. Akhilesh, if you ask me, that's a hardcore statistics, but I'll tell you the basic reason behind that. When we talk about the basic aspects of statistical understanding, the allocation, the blinding, the intention to treat analysis, bias rule out, power calculation, clear and precise formulas for finding out the intervention differences, and lastly, applicable. When you are talking about power calculation. So let's say you say that in your population, there is 5% incidence of what is called, let's say, mortality benefit because of any procedure like proning. Now, for identifying a 5% identification change, you need to go to a statistical sample power calculation and you say that I need to study 280 patients to show an 80% pickup of that 5% change in the mortality. That's a sample calculation. So if I only choose 166 patients, I am going to find with only 60% accuracy this particular difference that an intervention can bring about. I hope I am able to clarify myself.
Yes,
Yeah.
absolutely. Very important. Yeah.
So means if you say that my background attack rate of this disease is 10% and I need to study 1,000 patients to pick up with 80% success on that, then I need to include 1,001 patient. If I'm still including 800, I don't have the power to really show that the difference in the outcome is really meaningful, or maybe the confidence interval for that will keep coming down. So that statistical analysis power calculation is usually based on two factors. What is the background change that you expect, the percent or incidence? And for that, then you are looking at a reverse calculation of the number that you start with. But believe me, if you go by this hard power calculation, 40 to 50% of the studies never match the power calculation. So this is one of the biggest weakness of RCTs, that for kind of changes that we expect to be realistically true, we need unusually large numbers which cannot be scientifically done, which are prohibitively expensive, and heterogeneity of data will still preclude you to adapt it to your understanding. So it's waste of money. So RCTs can be sheer waste of money, especially the negative trials, but they do teach about a lot of things, probably not focus on them. So the same EGT trial, which was EGDT, has become actually a negative trial, but we have learned from there what protocols will not help. But at the same time, that gives you a question that what would be the best way to treat shock.
So is this kind like the number needed to harm also? Like number needed to treat, the number needed to harm also?
Yeah, so number needed to treat is 1 by ARR, absolute risk reduction. While number needed to harm would be 1 upon the hazard ratio, or whatever, absolute hazard ratio what we talk about. So it depends upon, suppose you were studying about the harmful effect of a particular drug. So you didn't want to study about harmful effect. Let's say you were studying about the effect of vitamin C, but you actually found there were extra deaths happening in the vitamin C group arm. So then what is the absolute hazard ratio? So 3 people extra were dying on every 20, that means in every 100 patients. So 1 by 3, that becomes your number needed to harm. That means if you are giving 10 patients vitamin C, 1 patient can die because of the adverse effect or something like that, or selenium or any drug. So when you started with the drug, you don't try to find out the number needed to harm because it is unethical. But while in the study, if you found that there was some harm accruing because of a treatment arm, then usually you are ethically justified if the effect is big to stop the trial. And there you talk about the number needed to harm. So if there was an obvious harm happening because of the intervention in study, which was not your intention, so nobody would kind of do a study ki how much harm can happen by this kind of drug. So
Right.
So it's a result. I would say it's a secondary outcome measure, not a primary outcome measure.
Right.
Yeah. Dr. Ansari, there is one more question. I mean, the students have asked, do we need to look at the p-value or confidence interval or hazard ratio given a choice?
Beautiful.
I mean,
Beautiful.
what
Actually, I would say this is one of the best questions because all three actually have to be looked at, and that's very important. So when we spoke about like in ARDS with prone positioning, you are looking at the hazard ratio, which is actually, that means if your hazard ratio is less than 1, it is beneficial. So it is 0.8 means it is 80% less likely to harm than the standard treatment. So if in the standard treatment there were 10 mortalities, there will be 8 mortalities in this group. So you have reduced 2 deaths. So that way you can say absolute risk reduction is 2 out of 10. That means if you divide this, then you get the number needed to treat, correct? That's how it is. By default, if your number needed to treat is 20 and above, it's a useless article because that benefit is probably coming by chance, by default itself. If your p-value is 0.05, you say that it could be a chance, correct? That 5 out of 100 people getting benefited by proning may be chance. But if you say that I have more than 5 people benefiting out of 100 because of an intervention, it starts showing a signal towards benefit. If you have 20 patients benefiting out of 100, that is 1 by 5. That means number needed to treat becomes 5. Am I able to articulate that clearly?
Yes, yes, yes.
Yeah.
So when we go back to the same way, if I have 50% benefit, my hazard ratio is 0.5, let's say. Or let's say my hazard ratio is 0.5, but that is always in comparison to the control arm. So if I was keeping my patient supine, and out of 100 people, 20 patients died in my supine arm, and while when I was keeping prone, the same number, I had only 10 people who died. So I have 10 extra people whom I have saved, which translates to a hazard ratio of 0.5. Now that 0.5 hazard ratio, with what confidence I am talking about? So the confidence interval comes saying that it was 0.36 to 0.78, which means the total range of benefit could have been by saving 3 to 10 extra lives. But the mean number came out as 10. So that becomes your confidence interval. And looking at a population of 100, you get the p-value from. So these 3 things are actually very well connected to understanding one fact. How beneficial is that effect with what kind of data spread? You cannot say that my hazard ratio is 0.7, but the confidence interval is 0.1 to 0.9. This is all across the place. So a very narrow confidence interval for the data and giving you a strict, tight hazard ratio. That means 10 people are definitely being saved for every kind of 20 patients who are harmed in the other group. And then you calculate the p-value that out of 100, how many people actually have affected. And if it is more than 5, then it is not just a chance. So your p-value will be less than 0.01. That is one. So it is becoming more and more stronger that this is not an effect of chance. So hazard ratio, confidence interval, and p-values, they all are actually about the strength of association of the effect to the intervention.
Right. Sir, any light on bias in the study?
So there are 2 types of bias. One is when you are talking about, so I searched the literature about the use of methylene blue in malaria, let's say, and I got 20 articles on the net. Of them, 18 articles came from Nigeria, Tanzania, Zambia, Congo, and all of these. And that makes sense because that's an endemic zone for malaria. But I got 2 articles from Yugoslovakia and Czechoslovakia also of 10 patients each. And there was shown a major benefit in outcome because of that, while most of the articles from Zambia, Chad, Tanzania, Zaire didn't show any benefit. But these 2 articles, and these 2 articles may have different numbers, can skew the whole result, and that could be the simplest bias. That you are not looking at the target population or where the disease is not so prevalent, you are trying to look at the benefit there. So that's called as one of the simplest publication bias. Now, surprisingly, these 2 articles, which came from non-endemic zones, are published in NEJM, while the other articles are published in some unreputed African journal of infectious diseases. So you give more precedence, and that's called Tower of Babel approach. That you got a better article in Nature or in Time or something like that, and you are very happy. And finally comes database. Now, these other data were probably very small. Let's say these articles which were coming from African countries were very small databases, while this, let's say, had a huge database. And that is also pulled up in the global malaria endemicity or fighting program, and this gets cited there multiple times. So this article, which is actually not a great article and is not coming from the real target population. I would want a target population of a tropical country. Is coming from a non-tropical country and talking about those few immigrants, travelers who have come from any area, who are found malaria positive on their blood test, and that they have reported that we successfully treated them with vitamin C or methylene blue, can give you a completely erratic idea of what you are talking about. So that could be what is called 4 biases in one: publication, Tower of Babel, database, and citation bias. And the hardcore bias during an RCT could be while you were selecting some kind of people who are diabetic in one arm and non-diabetic in others. Or there were 10% extra diabetics in one group, and that's why there was more mortality, and you didn't attribute that to it. So that could be a selection bias. While you are performing the test, you were making the doctor very clearly aware what was going to one arm and what. Methylene blue, it is a blue color solution, and you are not blinding the other treatment arm by a blue color of IV fluid. So that's a performance bias. And finally, you excluded out the bad outcomes of renal failure, saying later on that this patient developed renal failure. I'm not counting it into it. Now, methylene blue could have caused renal failure, and you have kind of hidden that aspect. And you did no intention to treat analysis में उसको लेना नहीं है, MITT कर देंगे. And then finally, a detection bias. When your results came in, you had the confidence interval all over the place, p-values very bad, hazard ratio not very well calculated, not every data counted for, all those outliers were not discussed, or some loss of follow-ups were not talked about. So that could be the bias in a RCT. So these are two different types of bias. One is called as the bias in the location of the study. कहाँ से आ रही है? किधर से it is coming back from? The other is during the RCT in the steps where biases can easily be systematically planted. I hope that's clear.
Yeah, that's so much elaborative and very concise also. I mean, as far as the interpretation of the data is concerned, that's very important. What are the challenges that we have when we do studies in the Indian context? We feel, I think we are still lagging behind, and we have a lot of problems like governmental interference, and probably there is very less support system for doing a good research in India. So as a matter of fact, if we want to advise the young budding clinicians, if they really want to do a study and
how do we start a small research? Any setup?
Yeah. I mean, I know that we have to have one question in our mind and we need to really follow that. But really, it has to come from within. But still, I think more than that, there is something more than this that will stimulate you to do study. And
so actually, honestly speaking, our teaching is more focused about what is called as clinical methodology and the things that we do, but not about understanding what we do majority of the time. So we are responsible. We usually don't look at what we have been doing in a daily practice. While in West, as a part of scientific temper, the students are encouraged to start, asking these questions, and it is very integral part very early on to be writing their own, observations in a scientific manner. So I think that's a scientific temper creation that starts very early, but we cannot run away. But in critical care, when we talk about, I think the first thing that starts is about, appraising papers well. We don't appraise papers well. From where you start understanding the grasp of these kind of questions. As far as doing is concerned, you look at all the workshops that are there in every scientific program. There is everything on ultrasound, on ARDS, on nutrition, and one hardly, a kind of workshop would be there on research methodology. You don't get resources for that. And now people are waking, and there are only a couple of universities or places where these things kind of flourish. So I think we need to create a culture where more and more people are encouraged to do that. And probably somewhere these need to be incentivized, where people can really do a good quality research along with their mainstream work.
So basically, it is the culture, I mean, that we have to imbibe the Western and
the learning curve. Yeah.
Learning curve is definitely there. It's really tedious. The interpretation of journals is also itself is tedious, and then we really, even if we want to do a research, we don't sustain ourselves thinking about doing research and all that, because most of the times we are preoccupied with some or the other clinical work or non-clinical work or some other work. So probably in this situation, what I feel like, we should, bring in a culture where some time should be dedicated for doing research only. So, I mean, apart from your clinical work and academic work, I think we should give enough time really to, work on doing research. But that's really not possible with the busy work that we have. I mean, I can say, I mean, this is like an exaggeration from my side only. I mean, but still, I feel like there is a lot, to stimulate individuals, and it has to come from us only. I mean, we ourselves have to set an example. We have to set benchmark, and probably then only people will be able to follow. Probably, I feel so. So, any other question?
No, I don't think so. With the interest of the time, I think we can wind up today's session. And many thanks to sir. It was a wonderful session and really appreciate it. And
Really, thank you, Ramzan.
Thank you, thank you.
I mean,
I was just going through the chat box. Thank you, Dr. Guru, for joining us. If Dr. Guru is still there, and he has put on the chat box. And thank you, everyone. I honestly would like to say that this was not the best of the talks, but still, I think this is a complex area where too much of technical talk should be avoided. Probably basics should be grounded well, and everybody should actually do more appraisals in your institutions, and you will automatically start learning about these terms. You cannot learn one day all these statistics and then go and read a paper. You read the paper, keep learning side by side, because these are complicated terms. But the whole idea should be these mathematical tools are applied to look at the trustworthiness of the data. That's very important. So a little bit of understanding of that is important.
But you made it very simple, sir.
Thank you.
Yeah, you made it very simple, and I hope the students have enjoyed it, and it will be available for them also later on. And with this, I would like to conclude the session, and thank you once again from the bottom of my heart and on behalf of the Department of Critical Care Apollo Hospital. I again thank you, Dr. Ansari, for this wonderful deliberation. And next week we have a discussion on heart-lung interactions and transpulmonary pressure monitoring. We have Dr. Tabul from France who would be coming and delivering the talk. So that is what I can say for you. Let's just meet again next Friday. Till then, goodbye. Stay safe and stay happy. Hope to remain connected. Thank you very much, sir.
Thank you. Thanks.
Thank you. Thank you.